So today I have a guest. This is Cath.
Hi.
Catherine. Don't call her Catherine. Her name is Cath. She is part of the team at Don't Miss a Beat. She's collaborated on our diagnostic peripheral book, although I think I asked her questions about everything anyway, but that was the main one you worked on. But she's done a little bit of everything. So I will let her introduce herself.
Oh, my name is Catherine, or Cat. I don't go by my legal name a lot, but it's fine. I'll respond to it.
Catherine.
I've been working for probably 7 years now as a tech. My hospital specifically, we do all three positions, which is pretty fortunate, and not a lot of hospitals do that. So I am trained basically to be a nurse in the room and stand in that position, which is pretty sweet. I do a lot of procedures. I think the only procedures I don't really do is TAVR.
I mean, you have.
I have done it, but I'm not officially part of our TAVR team, I guess, if you want to put it that way. But I do mitrals, I am doing vascular procedures, I do, whenever we get ECMOs, I do ECMOs, whenever we get tandems, I do tandem hearts, do a little bit of everything, which keeps the day pretty exciting. It's always different, it's never the same thing all the time.
Say, because a lot of people are hybrid labs, your vascular, structural, and cardiac, and then EP is separate.
Yeah, so I mean, I think compared to other hospitals, I mean, obviously I've been in this one, the departments, like, we can see each other, which I know, I think, like, in the hospital you used to work at, it was like
segregated,
but we do see each other. But yes, it is like separate procedures, and we did have a time where like they trained us on doing implants and pacers, but times have changed, so we're not doing that anymore. But I'm not surprised if it makes its way back into our lab. Been teaching for a bit at the school as well.
A program.
Yeah, a program. I did teaching as well, just to help out for summertime. And now
preceptor trainer.
I also, preceptor.
And you hold the phone.
Well. I do. I have been charged as well, usually like in afternoons. But yeah, I do a lot.
So, and then background-wise, what's your title?
Oh, like CVT tech?
Mm-hmm.
Yeah. So
not everybody knows what that is.
Yeah. So Cardiovascular Technologist. In our hospital, we have like, depending on what hospital you're at, for us is like, some of them are a max of 3, but ours recently, we go to a Tech 5. So you start as a 4 because eventually you're gonna be doing everything. But now it's become a Tech 5 because we do have more structural procedures that are coming in, and it's like very specific on like who gets to be the Tech 5.
Motivate you to learn more.
Yeah.
In big quotes. And you went to a program for this, right?
I went to a 2-year program, so you get your associate's degree, and then while I was in the program, there's opportunity to do your bachelor's as you're doing it, which like was great. And when I was doing the program, they had like a new one for leadership, which wasn't there before. It was kind of new. So I did do that track.
Yeah. Cardiopulmonary sciences focus in leadership.
Yes.
Did you have an AA before you did the AS program?
I did. I had my associates in arts. I took college courses while I was in high school.
Yeah.
And then I probably had maybe, when I was like trying to figure out what I wanted to do, I finished my associates. So I was like, why not?
I did
have
the same
credits.
because I didn't know what I wanted to do.
Yeah, and it give you time. So I got my associates in art, so it was like another year. And then by that point, I was like, oh, this sounds pretty interesting. And
yeah,
here we
I'll
are.
do another associate's. And
I was like,
different.
yeah, I'll do an associate's and
associate in science is different because it's very career it's like I always say the game of life where you choose the college debt or you choose career.
Yeah, or you just go
AS
straight
is
into
like
working.
career. Yeah, it's a little cheaper, and then you go immediately into working, and then you can do additional college later on. Or if you do an AA, BA, then you're kind of doing like a 4-year track to then get a job.
Yeah.
Usually.
Yeah.
I mean, you can have a job, but to have like a, what would they call it? Entry level, like career job. But yeah, I mean, I did the same, so I can't, which is why I thought about it. I was like, the only way in Florida you finish your bachelor's that quickly is if you have an AA, because then you have all the gen ed requirements, or Gordon Rule requirement, whatever they call it.
Because if not, you'd have to like take a humanities course, and even then,
Math.
like to get into the associates in science, you needed
Some of
probably
them,
a majority of the requirements for your associates in arts anyways.
Yeah.
So like by the end of me finishing my associates in science, I just applied to finish my arts because I was like, I already have the
Claim them, yeah.
yeah,
Or
I can
they go
claim
away.
them. Yeah, exactly. And then the bachelor's, I took it slow and I worked while doing my bachelor's. This is all online work.
Yeah.
And I was able to finish it also in a year.
When you do something like that, that's meant to be for working professionals. Most of it is online.
Yeah.
You chose a track that was 100% online. Right?
Yeah.
Mine was too. But now they have the Echo that isn't. But you can kind of choose something that is 100% online, so you can do it while you're working. You don't have to like do clinical and all that stuff. What does a typical day look like for a cardiovascular technologist in the Cath lab? Take me from the moment you clock in until you go home.
I will take you step by step. What I do.
Breakfast.
You come in, you leave your lunch in the break room. No,
Right.
So
Don't be those people.
yeah, I mean, I guess if you want to put it in that aspect, yes, you come in, you clock in. We have our locker room. I think every hospital for the most part. Yeah, you might not have a locker room.
I think some just have like a hybrid bathroom.
Yeah,
locker.
where like they have lockers. So
Yeah.
like for us, we have our break room, locker room. You can leave your stuff in there. We are allowed to have. So I guess a little bit different with ours is like we have a red line since we do like, in a sense, surgical procedures. So we're only really allowed like very small bags in the back. So, small bags, you can bring like your drink because we have our little drink station. We have like a little morning huddle that we like to do. So everybody will come in before cases start. They kind of let us know the rundown, if there's any changes, if there's any things that are like in back order, if there's anything that we need to look out, if there's, students coming in or if there's doctors coming around. Basically, it's kind of like a, hey, heads up, this is what's going on for the day, this is what's in the clear. And then we have our paper with like our assignments, and it kind of gives also a summary of what was talked about in the meeting. And we have like our important phone numbers for the rooms, for any emergency situation, for your management. Grab our papers and you kind of go into your room. So the way ours is set up is you have like your charge in the room. They have, they're labeled with like a P. So the P stands for is like Pyxis discrepancies. So they're the ones that check the Pyxis to make sure there is no discrepancies. Like, if someone didn't forget to waste, they kind of like check to make sure everything's working with that, make sure the room is working. Our second person underneath that, they'll have stars. And so the star stands for the person that's going to circulate. They'll be the ones picking up the patient, setting up the circulator duties. We're a very high volume hospital, so we're doing maybe 30, 45 cases a day. We have 7 labs, 6 Cath, one of those being, and then the 7th one is our vascular lab. So we are always busy. So it's kind of like you come in, everyone figures out, if you're circulating, you're going to pick up the patient. Sometimes there are some people that they try to make it fluid, and if you're always picking up a patient, you're like, hey,
I was going to say, so is it already decided who's circulating the first case?
Yeah, it just makes it easier to, because that way, like, so you have your P and then the third person's like, that's the third person in your room.
Got it.
So between those 2 people that don't have the stars, you decide, do you want to document the procedure, or do you want to scrub? Again, depending who you're with, some of us are like, hey, do you mind if I scrub? Like if you know.
So I guess the point of designating the circulator is so someone gets the patient.
Yeah, it's like, so who's getting the patient, and it does make it easier, especially if you have like new, like newer people. It gives them the flow of, hey, you're gonna go pick up the patient. This is what you're gonna do. So a lot of the times, like that person's already checking as quickly as they can, like who the patient is, making sure on the computer, like what the consent's supposed to look like, maybe any lab work, and then however much history you can get on the patient if it is there. Obviously, like if they're coming from the office, they'll fax those notes over. But they'll go pick up the patient, And then the other people will kind of set up the room, help out the circulator where they can, which is like pulling the meds, setting up the manifold. You know, we're also checking stock, making sure that, okay, do we need to stock anything? We do have a night team, which is great. I don't know if a lot of hospitals have that
a lot
either.
of places have some sort of overnight inventory team who's doing the lab inventory. Not all, of course, but a lot of people do.
Yeah, so ours is like, we do have a night team. So that can look from just one person, or it can be 3 people on a night, or it could be 2, you know, it's their own team, like they do their own schedule. So they also stock our rooms during the night, which makes it great for us in the morning, since again, it's kind of hard to find that time to stock the rooms where you can. So that's typically how morning looks like.
And when you start your case, after the first case, is it a set, because everybody does everything?
Yes.
So is it a set rotation on like whoever monitored goes to circulate, or is there a discussion on how that's going to go? Yes.
So usually, to make it easy, it's if you scrubbed, you're up to pick up the patient because you're going to document. Circulator's up to scrub. Person who documented is up to circulate, but they have to go drop off the patient. Change sometimes during lunch relief. So the way it works.
Lunch relief?
I know. What? That's crazy, guys. Wow.
Is that a thing?
Things work out. There is a lab that is designated to be lunch relief. So they finish cases at 11. They go to lunch at 11:30. They're kind of separated into different labs. If there's, let's say, a lab of 4 people, oh my gosh, 4 people.
I know. Right?
Then they relieve themselves. But if things get hectic, it kind of figures itself out. We find ways.
But I like that you have, just like when you have late team, like evening relief.
Yeah.
I've literally never heard of a designated lunch relief team.
Yeah.
Like a float person, you know, usually if there's extra people for the day, then they're your lunch relief. But it actually makes sense to designate a lab that's going to.
We have to.
As a previous educator and preceptor, what common misconceptions do students or on-the-job trained people have about working in the cath lab? Ooh.
Oh, man.
Like if people come in and you realize they're like, oh, this isn't what I thought it was. Like, what do they think it is? Or what are they not ready for or think is too difficult?
I think for us, it's the speed. I know, at least, because we do get students from like our school that we went to, so we kind of tell them, hey, some hospitals are like a lower volume than other hospitals. So I think what catches them off guard is how quick things actually go.
Yeah.
You know,
like case to case.
Yeah, case to case. It's like our turnover is maybe 10, 15 minutes between cases. So I think that's something that kind of takes them off guard is, oh, wow, this is what, like, for this hospital specifically, this is fast. Like,
and it's very physically demanding.
It is very physically demanding. You know, you're on a busy day, your one lab could be doing 12 cases.
Right.
On a not so busy day, you're doing maybe 3 because it's a mix of anesthesia cases or very complicated procedures. So not every
it's not
day is the same.
3 short things. It's out of the 12 hours of the day, you only got 3 done because they were so long.
Because of how long they were. Right. I think that's probably something that like students and people, if they come from a different department facility, are like, oh, this is.
Well, there's a lot of people
fast.
like, you know, people who didn't go to school for this. They're nurses, paramedics, respiratory therapists, rad techs, nurses from obviously other departments, and I think they all have a conception, if they've never physically been there and just taken patients there, on what the cath lab is, and not necessarily what it actually looks like to be doing it. So I'm sure, because it's very fast paced, screams efficiency, so it probably looks really, really easy. Yeah. And then when you go do it, you're like, oh,
yeah,
this is not easy.
And we hear that a lot too. They're like, wow, you guys make it look really easy. It's like, you don't realize we're making it look easy because you know what you're doing. Every time, like when I'm training a new person, I tell them, I'm going to train you how to set up your table like it's a STEMI. Yeah. You're going to set it up like this every single time. I'm going to time you at a certain point because I want you to have your table set up under 5 minutes. Right. When we were in school, we had 10?
Yeah, and it felt like
Yeah.
not enough.
And it felt like not enough.
Yeah.
That is a luxury for us to
Yeah.
have 10 minutes. We're setting up 5 minutes, and even
Yeah.
if it's not an emergency, doctors are scrubbing in.
Right.
They have to get
That's
their
just
cases
the
done.
natural pace.
That's that's how it is for us. So, you know, that's something too, like, this is how we're going to show you. And yeah, we'll get people and they're just like, oh, you actually like work with the doctor.
You're expected to say something if you think something's off.
Yeah, you know, like to say something, not be afraid to speak out.
Mm-hmm.
And, you know, we work with doctors where like we work together. There's doctors asking you for your opinion on like maybe what should we do with this patient. Obviously, they're gonna make the decision by the end of it. But there's times that they're just like, okay, like that's not a bad idea. That sounds good. Like let's do that. So, you know, you have to be able to get out of that. I want to say
Not fear. It's just the culture. A culture.
Yeah,
you're
a
used
culture
to.
of not feeling like you have a say in patient care sometimes. But you know, you do. You can say, hey, this is a concern. Obviously, like whether or not they listen to your concerns, that's a different thing.
Right.
But for me, as long as I said it, that is really the important part for myself. Like it's better to say something than to stay silent, and then it just eats at you behind your head of, oh man, I should have said something.
And if something happened,
yeah, and
you're
then
like,
if something happened, you're like, oh,
something.
exactly, I should have said something.
Yeah. At the end of the day, like I'm here for the patient, and
Yeah.
that's why I'm saying. I'm not saying something to question your authority. I'm saying something because I've seen it make a difference in a patient's care. You know, so I do think it's very different in that way, and I can see a lot of people are off put by it.
Also, I'm sure experience too. Like as you're there longer, the doctors get to know you. It does get easier to kind of hit that rapport with them, be comfortable to say something. Because I mean, when I first started, I was like, I have no business saying anything.
What if I'm wrong?
Yeah, exactly. What if I'm wrong?
Yeah.
But you know, there's also a way to. I feel like you learn also how to word things and how to speak in a way where you're not questioning them. You're asking it as a question. You're like, oh, you know, or you're not. I wouldn't say like making a suggestion, but you're just like, hey, you know, like
trying to learn why we would choose this in this scenario.
Why wouldn't we do this? And then, you know, maybe if you say it in that way, they're just like, oh, actually.
We do have that. Yeah.
We can. And, you know, that's just like over time. And then like when they get to know you, they're like, oh, okay. Like,
she's doing this because she wants the best outcome for the patient.
Yeah.
It has nothing to do with
or like, I can trust this person to like give me a decent idea.
I've been listening to a lot of Bill Lombardi's podcast, if you haven't listened to it. And he talks to a lot of young interventionalists that he trained or fellows. And he says that a lot. Like, it is hard not to take it personally. And I understand from their perspective, it's their craft. You know, this is what they went to school for. They're already scared of not making the right decision. And then someone questioning that kind of derails some people. And like, they're human and they have just as hard of a time as what comes off as constructive feedback, but really is just trying to give all the options for the patient. It's hard on both sides not to take it personal. So how you word it, thinking of if you were in their shoes, getting a suggestion like that, how would you take it immediately, is how you need to apply it in your delivery. You know, and there are definitely people who do it to demean a physician or to make them feel stupid. And the truth is, yes, they went to school, yes, they went to training, but stuff changes all of the time. That might have been the first time they saw that device, or they don't know that this other device is an option. We have it, and then you got training on it until you say something. And it's not to be like, how do you not know how to do this? But hey, like, did you know we have this now, and we have this, and you can do this? And they're like, oh, actually, no, I didn't know that.
Or like techniques too. Like we work with a lot of different doctors. We see a lot of different things. So like there may be some techniques that they've never done or never seen, and
not like they have time to go.
Yeah, for us
watch
as
other
like
people.
the scrub tech, you know, if they're doing a case and they're having difficulty and they're like at the end of their wits of what to do, and they're open to the suggestion, and you've seen something that has worked, make a suggestion.
Yeah.
And
hey, I
if-
saw Dr. So-and-so do this. What do you think about
And
that?
if they want to try it out, great. And if it ends up working out, that's even better, because not only are we able now to proceed with like patient care, but it's something that's worked. Now the doctor is kind of like seeing, oh, this person knows like different things that I can maybe learn from them.
Yeah.
And it
They start to
develops.
ask you,
Yeah.
have you seen this before? Have
Yeah,
you seen
and you
someone
start
do
to
this before?
develop that relationship. And that's where like a lot, that happened to me a lot like in the hospital. Like I learned things, saw things, and I worked with other doctors and I'm like, hey, listen, I've seen this, it's worked. If you want to try it, cool. If not, I don't know what else
Power
to tell
to
you.
you.
Yeah, I guess, like more power to you.
What other option do we have?
Yeah, and then it's worked and it's helped me develop that like footing in my department or like, with some of my doctors, which is
You're
great.
not claiming to know how to do everything.
Oh, I don't.
It's just more of when you're at a high volume place, you see a lot of almost complications and you see a lot of troubleshooting, and the cath lab is way more DIY than I think people expect it to be. Like we have guidelines and we have algorithms, but 90% of the time it doesn't fit in the box.
Yeah.
And you can't just stop and go, oh, it doesn't fit in the box, can't do it. Right? A lot of the times we are their last resort where it's like, okay, like I have to figure this out. Or worse, a almost complication is happening and you're like, I have to do something to fix this. And none of the devices we have kind of accommodate that. And you're like, you know what? I saw this one time and we did this crazy MacGyver thing
and it
worked. Do you want to try it?
We call that the cowboy stuff.
Yeah,
you
yeah.
know, it's
Do
like,
you
it
want
worked.
to try it? Okay, so this was from a Reddit post. And I answered her question, but I'm curious on yours.
Okay.
This is a student in Canada, so a little different. I'll be, not all Canada programs are like this. I will be starting clinical in the cath lab in the next couple of months. Advice on the best way to prepare and not look like a complete idiot. Her words. I already plan to review my notes leading up to it. I came from a program where we mostly just monitor, which is kind of hard to stand out, I'd say, but I mean, there's still ways. So what is your advice?
Okay.
I don't think everything about being successful is knowing what you're doing as a student.
Yeah, I mean, as a student, I just feel like in general, people need to have more grace with anyone coming to the lab. I mean, like obviously, you're not going to know everything as a student. I don't know everything now. And,
correct.
You know,
Me either.
Nobody knows everything. And the minute you think that you do, there's a problem.
Yeah.
That's something that was told to me when I was doing my clinicals, and it stuck with me. Because the minute you think you do, that's where mistakes happen. And when you're not open to like either learning new things or learning to change, and it's a field that's constantly changing, and sometimes things that you're doing before that you thought was right isn't right.
Yeah.
But yeah, as a student, I mean, when I started, I'm not gonna lie, I was terrified. It was definitely out of my bubble. I'm such an introverted person, so to go to
talk to strangers.
Yeah, to have to talk to strangers and basically put myself out there and kind of defend myself and my learning.
Yeah, you gotta advocate for yourself.
It was very hard, and I mean my first site was crazy. But you know, I made it through. I just kind of, like you said, like the notes are great. Being open to just be in the case, as involved as you possibly can. Paying attention to who are the people that are willing to teach you, who are the people that are willing to take you under their wing. And I mean, obviously they probably don't want you to, but like being a leech onto them. When I was doing clinicals, this is just me. I kind of learned how they like their table to be set up. And then when I would scrub in with them, I would set up their table the way that they like to set up their table. And that was just things that I paid attention to. And obviously it teaches you different ways to set up your tray.
Yeah.
So when you're doing your own thing, you have all these different ideas.
Yeah, you're trying to make whoever that person's is their life a little easier.
But yeah, don't be afraid of the worst thing someone can tell you is no.
Yeah.
So don't be afraid to go up to either the tech or the doctor and be like, hey, do you mind if I scrub into this procedure? I can back scrub this, or do you just mind me being in the room watching your procedure? Yeah. Again, the worst thing they can say is no. And at that point, you know, it is what it is. There's only so much you can do as
and them
student.
saying no to not scrubbing. I've seen a lot of physicians and staff be impressed by then still putting lead on and going in.
Yeah.
Unless they're like, no, I don't want you in the room, and they explicitly say that, okay. But not scrubbing doesn't mean don't participate. It just means you can't participate in that way, but you can still show interest.
And that's a huge thing. I've seen it times with like different students. They'll come and they'll just sit in the back, and you're just like, okay.
And a lot of people think like, I get scrubbing is the goal to a certain extent, but it is a little offensive, I guess, if, oh, well, I told you you can't scrub, so now you want nothing to do with the case.
And even then, I mean, if it's not bad to sit, like, I'm not saying it's bad to sit. If it's been a long day, sure, like, take a seat. You start to notice, you're like, okay, like, the thing is, when, at least what was told to us, every day is an interview.
Yeah.
So you know, they're interviewing you in some capacity to see your integrity, to see your character, to see if you're a fit, but also you're interviewing them because you're trying to figure out, would I be a fit here? Is this something that I like? And obviously that would be like maybe further into your clinical experience when you are deciding where you want to work, but it is an interview to you as much as it is an interview to them.
A lot of nonverbal things that somebody who doesn't know you, and these people don't know you, read differently. So like if you were sitting in the monitoring room and I was scrubbed in and I didn't know you from Adam and I looked, I would assume because you didn't have lead on in the room that you were disinterested, even if that wasn't the reason. You know, I don't know what the rest of your day looked like. I don't know any of that. Same with why I always tell students, if you have notes, have it on paper, don't have it on your phone, because you looking at notes in your phone, someone walking by doesn't know that's why you're on your phone. That's not the first thing they think of. Oh, they must be on their phone looking up the notes that they took last night. They're not going to think that. They're going to go, oh, they're on their phone, of course. They're not paying attention.
Exactly.
Versus if you have physical, like old school notes, it might seem monotonous, whatever, but like generally everybody understands that's for education. Yeah. That it comes off that way. Even, and let me tell you, people 4-5 doors down are looking at you to see what the student is doing. You know, they don't have full context.
Everything. Even if there's not a student in my room, or like it's someone I've never seen. I'm like, who's that?
Who are you?
And then like you're looking and you're just like, oh, okay, cool. They're like actually involved. Or like,
and they're helping. And,
they're helping in some way. And then you remember that. And then when you see them, you're like, oh, okay, this person's willing to do something. And people talk. So, you know, things spread very quickly in Cath lab. So you may have had a day with this one person in this one lab, or a day with this team, and by the end of the day, everybody knows about it. Everybody knows about you. Everybody knows if you did something wrong, or if you didn't do something wrong, and you're gonna do something wrong.
And you will get made fun of.
There is no way around it. Don't try to be perfect, because I feel like when you try to be perfect, that's where mistakes happen.
The worst.
You need, and like people need to learn grace for themselves and know, because there's going to be a time, let's say you never did a problem you never did any mistake as a student. I did mistakes as a student. You're not perfect, you're learning. But if you're, let's say in your field, working as someone that's like actually part of the team, and you end up doing a mistake, and you don't know how to come back from that. Because you've never made a mistake before. I feel so. That's why for me, even if you look how people say like, oh, I look stupid, or oh, this is like, there's never a stupid question, because you're learning.
Yeah, you only know as much as what someone teaches you, and if the person who taught you didn't make a point to say something about it, you might not know. And to somebody, they might be like, well, you should know that. Okay, well, the only reason you know it is because someone told you.
You're born and you're just like, I know all this Cath lab experience. Like, no, everyone learns from someone
I mean,
else.
there's tons of, how many times do you see the videos on TikTok of like, did you know that's what this thing is for? And you're like, wow, I feel stupid. Oh. But nobody knew. That's why everybody watched it and liked it, because it wasn't obvious.
Granted, there is some times where it's like, that really isn't what that's for. You just kind of figured out that this could make something
have
cool.
Another purpose.
But there is sometimes that it's just like, and it's so funny because like it says in the directions too. Yeah. You don't read the directions. You're like, oh, it's fine.
IKEA furniture, I can figure it out myself. Thank you. I don't need these pictograms. Oh, someone asked, what is your favorite procedure and why?
Oh gosh. My favorite procedure. Oh gosh.
Favorite, one you enjoy.
Do I even have one? I guess emergencies.
Okay.
Yeah. So, I mean, I guess it's not a procedure, but
No, but it's an umbrella of
yeah,
certain things.
I like emergencies. I am a sucker for the adrenaline rush when the patient's coming in. When I think it's more because it's kind of like I make it a test on myself because you have to prioritize what's important. You're moving at a faster pace, and things are getting thrown at you a lot. So you could be
when you're
like,
talking to me, it sounds like the final boss of a game.
yeah, but basically, where you're just like, yeah, let's do it.
I have this strategy that I do, and I know I need to do this.
So it's just kind of like a little test on yourself. You're just like, oh, okay, cool. Like you're getting an impella thrown at you, or like this balloon pump, but also like the doctor's trying to get access, or he's gotten access and he wants the guide, and you're like trying to figure out a time to set up this while also doing this. I think it's because there's more for me to do in that procedure than just your standard intervention. And I'm like, oh, okay, cool. Like I'm very, very busy during the case.
Yeah.
So I personally like doing emergency STEMIs. I'll be in a case and it's just, I'll be in a structural case. They take forever, you know, sometimes they're 2 to 3 hours. And next door they're getting like a train wreck. And I'm just like,
I want to be over there.
I want to be where the people are.
I want to be where the emergencies are. I had a student say, I think Cath really enjoys circulating emergencies because she always inserts herself.
I do. I do. I don't know.
Well, it's good. Not everybody thrives in that environment.
Yeah, I tell people like when I have students and stuff, I'm like, oh, for me, when I'm circulating and I'm mixing, I feel like I'm baking because, you're getting this much fluid and you're putting it into like this concentration, you're making this and you're having all these drips. So I love, when I'm in an emergency, I'm like, I do like to insert myself when I can into these emergencies.
Some people, again, don't enjoy that, and some people do. And you should challenge yourself in other ways, but if there's something you're really passionate about, it makes, all the other days where you might not be doing your favorite thing, worth it.
But that's the other thing, like how you literally just said challenging yourself. That was the only way. It was either be afraid of these procedures and feel like I was behind, or just getting out of my comfort zone and putting myself out there.
Rotablader. I kept inserting myself into them when I first got hired, and I struggled. And I would tell the physician, I'm like, please just let me struggle through it. Like, let me do this because I'm never going to get better if you don't just let me struggle through it. And then I got to the point where then if somebody else was struggling, a physician would be like, hey, can you show them how to do this a little better? And I'm like, yeah, struggle through 15 of them and then you'll get better.
Yeah, because there's like the new way where like you have like the little the support thing. And I had a time, we had no rep. I hadn't done this in a while because it's very far in between that you do these procedures. And I remember I had the physician with me and he was like, oh, do you know how to do the thing? And I just went, I don't know how to do it that way, but I do know how to do it the old school way. Is that okay with you? And he was like, yeah, that's as long as the wire stays in place. And I'm like, okay, cool. I'm glad we have this understanding.
Yes, I'm the same.
And we got everything out perfectly fine, and that was that.
How many years of experience do you recommend to have to become a device rep? Best case scenario, because there's a wide range. There's some device reps with no
and that's
clinical
the thing
experience.
too. I mean, again, I was 2 years in and I had reps asking me if I was interested in becoming a rep. Simply, it may not have just been from my experience, because I feel like I had no experience at all, but also they see how you are with the doctors, how you are with these procedures, and how you hold yourself. So, I mean, I don't think there's a really good, maybe 4 years, I would say. Because I feel like the first 2 years you're learning so much in the field, and then at least like the next year after that, you're kind of solidifying everything and then coming into your own person. So I would say maybe 3 to 4 years would be a good range.
I'd say that's like the perfect storm to have, is that you have 3 to 4 years of experience in a lab that's using whatever device you're trying to go to. because that doesn't matter too much if you're in a lab that like only does IR.
Yeah.
I mean, you get procedurally and flow and culturally like where to speak up and what you can do, but it's not like you have extra knowledge on that specific thing. But yeah, I mean, I think it depends on the person, because you could have someone who has a ton of experience and industry just isn't for them.
Yeah, the person, like, I wouldn't even say, I guess, personality, or just like that's where it comes into play of
if
like
you've
how
grown
you
professionally.
are. Yeah, how you are professionally is just as important as how you are with your experience as well.
Yeah, I agree. And I think, and I say this a lot, whenever anybody asks me this question for like traveling, to go into peds, to move over to EP, at what point should I do that? It's what makes you successful in the role? Being a professional, being able to advocate for yourself, having, like let's say working for Impella, having a really, really good foundation of hemodynamics. Whenever you meet those goals, then you're ready. If it takes you 1 year, 3 years, 5 years, then that's it for you. But it just depends on what the requirements of the job are, because there's definitely reps who are not medical at all.
Yeah.
And get thrown into it. But they have a harder time building staff trust, and me trusting your education and your input to speak up in this instance. A lot of those reps do doubt themselves, and it takes them longer in that role to then build that confidence. So I think it just depends on who you are.
It all really depends. And like no one can really tell you when is a good time, because for yourself. I mean, it's even now, and like there was times where I was interested in traveling and I just never felt like I was ready. And even now
you're never going to be ready.
You're never going to be ready until you do it and you find out, do I like this or do I not like this? And there's nothing wrong with that. You go into the field, you try it out for a bit, and then if it's not for you, just go back into the lab.
I felt so prepared to go into industry, and I knew so much, and then I walked into the OR, and like I said, I was like, I don't know how to speak up in here. I don't understand anesthesia's job, because in the lab we don't really work with anesthesia too much. EP does. CVICU. Truth time. They kept telling me, patients on CRRT. Like, CRRT? What is that? So then I would send my boss a picture of the room, and I would be like, please tell me which of these devices is CRRT. And he's like, the dialysis machine? I was like, I don't know. I was like, I don't know what that is. And there was so much I had to learn on that end. And I just had so much to learn about. I'm like, they probably think I'm an idiot that I don't know what a dialysis machine looks like, but I don't take care of patients on the floor. They don't bring that with them to the cath lab.
Yeah, I mean,
it was new for me, and I'm sure I looked like an idiot, but I knew a lot at just that. The other sides of that I had never been exposed to. So I wasn't ever going to be perfectly ready. And there was a lot of echo, and echo is my weakness. I knew that going in.
I did. Echo is my weakness, and that's all I had.
I was like, I'm always going to have to take a picture of this and send it to someone. Be like, this is right? I still was never confident enough to say, like, yeah, this is positioned well. Yeah, this because if a patient's relying on you, or they're looking at you as the expert, you don't want to tell them, yeah, 100% it's good, and it's not.
Yeah, and then it falls on you.
Correct. That's the other difference with industry, is you are seen as the expert, and sometimes you're teaching a physician how to do something for the first time, and you have to be comfortable being like, I need to phone a friend, because there's no friend in the room for you.
Yeah,
Let me go phone my boss.
It's even me with like, I've seen a lot, I've done a lot, and I still am like, I need that second verification. I need it.
Once that little seed of doubt is there, you're like, nope, I can't move on from this. I have to go get
somebody. Oh no, I'll have it all the time. I'm like, nah, I don't. Even if it's like some form of medication, I could know how to do this medication like the back of my hand. And I'm like, I'm gonna pull my medication book, make sure everything's good. All right, we're good.
Well, I guess there's no, all it is stroking your ego a little bit, like safety over everything. And I would, as staff, I would trust somebody who goes and checks themselves versus telling me something confidently incorrectly and not being willing to double check themselves. How do you overcome the fear of doing complex procedures? But the second one that goes hand in hand, my lab does not let me do anything. I am new, and they only allow the more experienced staff to do the complex stuff. How am I supposed to learn? So I think one is personally how to advocate for yourself, and then you can speak from a staff perspective. Who are those people jumping in?
So as personal, at least in our hospital, we have our reps that are there all the time to do like your in-services and stuff. So if you have the chance to go there, and even if you have done it before, it's been a while, go there to get that refresher. Even if you're not going to do that anytime, just keep going, getting refreshed on these devices, no matter how many times you've done it, because you never know. There's something new that is going on. And obviously, again, it's like if you have the time. There's days like I'm really busy and I'm like, rotablitter's there, and I'm like, I just don't have the time to go. And then next thing you know, the rotablitter is in my room, and I'm like, all right.
I should have gone to the insert.
Should have gone when I could have. But what I like to do is, if the rep's there, at least like our reps, they'll come and they're like, hey, you know, like, how do you feel? Can I like go over anything with you super quick? And I'm just like, yes, please. And as we're doing the procedure, I'm like, you need to tell me.
Yeah, they'll be like, remember, I showed you.
Yeah,
this.
Just, and the way I kind of tell them is, I'm like, can you just tell me as I go? Because that's the way I am, and need to say it ahead of time for me to do it fluid, like to make it look fluid. So that's kind of what works for me whenever I'm doing these procedures. What really helps me feel comfortable is, especially if it's not a doctor that's like super comfortable doing the procedure, is the people in my room. I was very fortunate that I worked with people at that time, and then like I still do. It's just like now you're that person, so you're kind of like, what's going on?
Who is my help?
Yeah, who's my help? But yeah, at that time, I had a lot of people that were willing to help me, and so I would tell them, I'm like, listen, I will scrub this case. I just like, this is where I'm at. Please be there to support me, and they were there. They were there to support me, and that was a huge help. And you know, going back into the experienced staff members not letting you scrub in, it's gonna be hard. You'll work with some people that it's easier for them to just do it for the doctor because they don't want to deal with whatever repercussions, or they don't want to deal with their tantrum. I really try not to.
I'll say it's hard. Giving up control is very, very difficult.
It is easier to just
do it.
But at the end of the day, there's going to be a time that, and I tell this to the doctors, I'm like, you're going to be in a room where those people that are experienced are not available to you. And because you weren't willing to let them learn in that controlled environment, now they don't know what they're doing. So, you know, as long as you communicate with the physicians, this is the situation, or even like communicate with your management. I remember I had a moment where it was going to be a complicated case. We're going to do a device I hadn't really done, and I was up to scrub. And I just remember someone coming and like, they were going to scrub me out, and I was like, what are you doing? And I mean, at the time, I didn't realize how big of a deal it probably was, but they're just like, oh, you know, the doctor was just not comfortable having you scrub. And I was like, okay, they can come and tell me they're not comfortable with me scrubbing, but I'm going to scrub. And I kind of put my foot down, which was surprising to me because I was never that person.
Yeah.
I was just very like passive. I'm like, oh, okay, whatever. But I think I'm also very stubborn. So it made me feel some kind of way. And I was like, no, if you don't want me to do something, you can come tell me you don't want me to do it. Don't send someone else to do it. Right. So basically in that sense, realizing now, like when I was like coming back, I was like, wow, I probably caused a huge stir because like they brought an extra person in the room, and then, you know, like that person, they ended up back scrubbing me, which is fine. Yeah. That's if we have the people to, like, if you have extra people, have someone back scrub them and still let them scrub the case, and you take over as much as you can. When I have students or when I have new people, I'm just like, you're not gonna learn back there. So when it's that time, you're gonna be up here and you're gonna do as much as you can. Yeah. When the doctor tells me to switch, that's when I'll switch. Right. But we're gonna push as much as we can. So yeah, they got that extra person in, and the doctor came in and was like, all right, like, let's scrub this case. Didn't mention anything about not wanting me to scrub the procedure. And I just told them, I was like, thank you, like, I'm ready to learn from you.
And sometimes it's you don't know what the conversation was if they don't come to you. Sometimes people interpret the physician asking, oh, who's scrubbing this case? Like you see a little hesitation in their eyes, and it's not usually they're trying to be mean.
Yeah.
The person that takes over for you is usually trying to protect you, trying to keep the physician happy, or they saw that they were uncomfortable or hesitating. And that will not change. That will always be the case.
Yeah.
Until you learn how to do it, to be competent enough to do it by yourself and to be that go-to person. That doesn't happen if no one ever gives you that opportunity. I mean, it might happen involuntarily, you get forced into it, and then you've never had that opportunity, and then you're probably going to fail, and you're probably going to mess up. And it's really no fault of your own if you were advocating for yourself, right? But those little opportunities, you do have to be stubborn.
Yeah.
Or you have to, you know, maybe not with the patient there in the moment, and allow them to take over for you, and then sit and have a conversation with them, have a conversation with the physician or your leadership, and be like, I need you to understand, I want to learn this.
Yeah.
I want to be good at this device, just like my rotablator scenario. But I need you to be patient with me. I need you to give me the opportunity. I've gone to the in-services, I've practiced, but I need to actually do it.
Yeah.
And you can be there with me, you can tell me what to do, but don't take over.
Yeah.
And 90% of the time, those complex devices we're using is not an emergency.
Yeah, yeah. It's usually, it's a controlled environment.
Yes.
And again, it's wherever it's appropriate. Obviously, if the doctor is still adamant about it, then, you know,
what they say
take the loss and circulate, and you can watch it from that aspect.
Yeah, don't leave the room.
Don't leave the room. I mean, obviously they're not going to make you leave the room. They'll just, somebody else is going to scrub it, but still insert yourself wherever you can and watch wherever you can. And I mean, I tell some people all the time, I'm like, listen, be patient. The case, you know, you may be seeing these cases coming in, and it's like, it's either not in your lab or you're not up to do the scrub, and you just feel like,
you're waiting
I'm
for your
never
time.
gonna do it. And
Yeah.
I tell them, like, the moment's gonna come. Be patient, get your skills up wherever you can, keep learning what you can. It's gonna land on you. And then you're gonna be like, oh, okay, now it's my time. And at least you've been honing in those skills to feel confident enough to say, yes, I can do this procedure.
Yeah. I think the number one skill, and I try to teach this to students in school, a completely non-lab day, I gave them a device, let's say rotablator Impella, and they have no context on what it even is, to teach them literally to be able to follow instruction. And it's a challenge. I think it's a good challenge that preceptors need to learn, to literally practice walking somebody through something without touching it.
Yeah.
Because that's hard. It's hard to, and that's, a lot of reps have difficulty with that, of when you've always scrubbed and now you're a rep and you cannot touch it, and you have to be able to teach that person how to do it, but you get more comfortable giving up control, because as a rep you don't have a choice. You can't just do it for them. So I think that's a good thing for preceptors to practice, and as a new hire to like tell people that. Just what you did. You articulated what you needed. I would like to scrub this. I have not done this before, but can you please walk me through step by step what to do, and I will do it. You're telling them what you need. You're willing to do it and be uncomfortable, but you're going to listen to them and need step by step instructions, and you're challenging them to give that to you.
Yeah.
You know, so I think it's communication on both ends, because not everybody knows, as an experienced person, how to handle that. Maybe they haven't trained somebody in a really long time. You haven't had a new hire in your lab in a really long time, and they're like, I don't know how to teach this to you. Okay, well, try.
Yeah.
Please.
And
Please
I mean,
try.
and as a new person too, or just in general, push yourself to do those cases. It's so much easier.
Don't avoid them.
Yeah, don't avoid them. It's obviously, just as it's easy for the new person to do it, it's easy for the experienced person to do it. It's easy for the new person to be like, oh, okay, yeah, they're just gonna do it all the time. That's where we have problems.
Yeah, it's not good for the same person to always be doing them.
Yeah, it's not good. And then, you know, staff members get pulled every which way direction for these procedures. Or they're all on, there's a day they're all on vacation, and now you have the new people doing it, and they haven't had the experience. And there's times where, like, I'll go in a room and a new person's like, hey, can you scrub this? I haven't done it. And I'm just like, no.
That's not how you're gonna learn.
And they're kind of taken aback with that. I'm like, is the rep here? And they're like, yeah. And then I see who the doctor is, and it's like a like amazing doctor to scrub with. And I'm just like, you're going to be fine. I'll be in the room.
Mm-hmm.
This person's in the room who's also experienced. We will help you.
That's a perfect
We are not going to
scenario.
let you fail.
Right.
This is the moment to learn this, because there's going to be a day that we're not here.
Mm-hmm.
And it's going to be you. And because you
And
kept
you're
pushing
going to
it
be
off.
opening the instructions for use and having them on the counter
Yeah.
and being like, okay, I
How do
connect
how do I
to
do this? So yeah.
Because a physician also hasn't done your role.
Mm-hmm.
They know what to do on their part, but they need you to do your part. They don't necessarily know.
It's so funny
how
to see them
your
try
part.
to like wipe wires, and you're just like, oh, just keep
Right. And that's why if you have fellows, teach them how to do all of that.
Yeah.
Teach them the other side, because then if they're with somebody who doesn't know how to do it, you can teach them. They'll be like,
Mm-hmm.
oh yeah, you do connect this to this, I think. And usually there's only one way to do it. So if it doesn't go there. It
Yeah.
goes
It's like it goes here.
But
Like the hype. I feel
The
like that's
hype.
where
What is the
the
hype?
problem is. Like they hype up like, this is like super,
This is
this is
so
gonna be
serious.
hard, this is a serious moment. And sometimes it is a serious moment, but like
They're
people will
all
be like,
serious.
they're just like, oh, but it's CSI. And I'm just like, you're just going over the wire. Can you hold a long wire, make sure it doesn't touch the floor? They're like, yeah. I'm like, all right.
the device will
You're
do
good.
what it is supposed to do.
Mm-hmm.
It has the hard job, not you. You just got to get it there and get it out. That's it.
And make sure nothing comes out. Yeah. To be very as calm as you can mentally.
Yeah.
In those moments, because there is a lot of hectic stuff going on, but nothing gets done if everyone's yelling at each other and not acknowledging. And I've been in those emergencies where
A lot is happening, but nothing's happening.
a lot is happening, nothing's happening. There's just a lot of yelling. Things are getting missed, and I have been in ones where, the doctor's saying something, it's being acknowledged, being said back, and being done. And that's like that whole closed communication, saying the person's name, knowing, but also like knowing as a person, they're doing this. I'm going to not focus on that
because it's being done.
because it's being done, and I know it's going to get done.
What
and
do I need to
being available to the doctor for something else. And that's something I feel like that's hard for some people, especially if they are huge on just like doing everything. Like the minute they hear something, they feel like they have to go do it.
Yeah.
But you have to realize there
Everybody
is
has
somebody
a role.
else.
Yeah.
Everybody has a role, and
You can't do everything. That's literally the opposite of a definition of a team.
Yeah, and if you're not listening or acknowledging, if I say your name and you don't say it back to me, that tells me you didn't hear me.
Yeah.
And there's times where I'll say their name again. They're like, yeah, I heard you. I'm like, well, I need you to tell me, like, you heard me.
Yeah, that's like, there's actually a very good, is it an ACLS that you watch that video, or BLS? They go
ACLS,
over
I
closed
think.
loop communication. Oh yeah, the mock
think it's
code that
ACLS.
goes well and doesn't go well. I have learned, tidbit, not everybody that works in the Cath lab is required to have ACLS training. Did you know that?
No, I
Yep.
don't know that. Okay.
Didn't know that either. But if you are not, and it is not required, it is, I think, just on YouTube with American Heart Association that you should watch the good code and bad code, and it goes over closed loop communication and how to do that. It should also be, I should put it in the orientation manual. It should be part of your training. I just argued with my husband the other day about that, because I don't know what I said. Something like, did you take the trash out? And he was like, yeah, I heard you. And I was like, oh, I didn't think you did, because you didn't acknowledge that and then say, like, okay, taking the trash out. So now he over communicates, and it's very annoying. But
You're like,
works.
I'll take one over the other.
Yes. I am going here and doing this. Okay, what am I doing? And I to going here and doing this. But it does work. So I appreciate all of your questions. Hopefully we got through majority of them. If there are more that we did not answer, just put them below. Kat is a very good friend of mine, so I see her all of the time, so I can just ask her and post it. How many times did you get called in this week?
Oh, this week? I have not been on call this week.
That's
yeah,
nice.
I know. No, my call's coming up.
Sorry,
my
let's
2
not
weekends are coming up, so we're a little premature, and I won't say anything
Or very
because
superstitious.
every time I say things, they go wrong. I have a black cloud, so I try not to say or think things because 9 times out of 10 it goes wrong.
Sorry.
But
We will update you on what her call week looks like.
my
when she
call
comes
weekend,
back.
my next
She'll remember this
call weekends.
conversation. Please like and subscribe this video if you want more like this, and then we will have another Q&A with someone who is, oh, by the way, she is RCIS, so she's CVT RCIS. We need to specify that. My bad. So maybe one day we'll talk about her
My
exam
stories.
experience because it wasn't great.
Oh, you know, it all starts there.
Yeah,
It all starts
when
at
the
the
power
exam.
goes out during your exam.